Advancing Safety Together. This is a joint SHOT and JPAC webinar. The webinar will involve a 40 to 45-minute presentation, followed by an interactive Q&A session, and then a feedback poll at the end. The webinar, as I've said before, is being recorded and will be uploaded onto the SHOT website soon after the session. Live captioning is available during the webinar, and attendees can switch it off if it is not required. Your microphone will stay muted throughout the session, and there isn't a chat function at this time, but we'd still love to hear from you. So please pop any questions you may have into the Q&A box, and we will do our best to answer these during the webinar or in the Q&A session after the presentations. The attendees are encouraged to record your learning from the session, and you can enter 1 CPD point for attending this webinar. And thank you very much in advance for attending. So without further delay, it gives me great pleasure to introduce our speakers for you today. Next slide, please, Liezl. Our panelists for today are Dr. Jayne Hughes, who's a speciality doctor in donor services at the Scottish National Blood Transfusion Service, chair of JPAC Standing Advisory Committee for the Care and Selection of Donors. We'll also have Dr. J.B. Mueller, who's a member of the donor medical team at NHSBT, Dr. Liezl Baum, who's a member of the donor medical team at NHSBT, Dr. Hasarika Dodampegamage, who is specialist doctor in transfusion medicine at the Welsh Blood Service, Rebecca Hutchinson, who is the regional lead nurse in Yorkshire, Humber and East Midlands, Nursing Care and Quality Team of the North and Blood Donation at NHSBT, and Dr. Shruthi Narayan, who is the SHOT Medical Director and a member of the Donor Medical Team at NHSBT. We're also very lucky to have support from members of the SHOT team today, myself, Karen Hughes, who's the Operations Manager, Juliana Morgado-Khan, who's the SHOT Data Analyst Specialist, and Bilkis Akhtar, who's our SHOT Administrator. Without further delay, I'll hand over to Dr. Shruthi Narayan for the first half of the presentation.
Thanks very much, Karen. As you mentioned, this is a collaborative session between the SHOT as well as the JPAC, and I thought that in this next couple of slides to just give a brief overview if people are not familiar with what SHOT is. So SHOT stands for Serious Hazards of Transfusion, and we cover the whole of UK, and we work very closely with MHRA as the regulatory body, and we are part of the NHS, but we are independent and professionally led Haemovigilance scheme. And Hemo is blood and vigilance is surveillance. So essentially what we do is collect the reports related to various incidents. So largely we are transfusion safety incidents, reactions, errors, near misses. This is collected from hospitals across the UK. We then analyze the report to understand what are the common recurring themes, what went wrong, why did it happen. That is, we don't get involved in the incident investigations, but we collect the themes that are coming through, mainly what are the things from a system level. We then share the learning. It is through our annual reports, through various guidance documents and other resources, which are all available freely on the SHOT website. And the main aim is to actually improve practices, both clinical as well as the laboratory one. But also what we do is everything is actually then primarily geared towards improving and enhancing the safety. It is safety for the patients, for the blood donors, as well as the staff. And we work collaboratively with all the various stakeholders, including the patients, to promote these best practices and reduce transfusion risk. And we're also very happy to actually then share that this year we are celebrating 30 years of Haemovigilance. The first time that SHOT report was produced was in 1996. So it is really a great event to actually then celebrate one of the earliest Haemovigilance systems to be set up in the world as well. Now, when we look at what Haemovigilance covers, it is actually covering the whole journey of blood. So right when you're actually talking about, having the blood donor at the end of the initial end of the donor pathway, through all the processing, the testing, as well as then the distribution to the hospitals, and then actually the transfusion happening. So Haemovigilance covers all aspects of this, from the donor to the recipient. Now, when we look back at the history of annual SHOT reports, it was, as I mentioned, largely recipient Haemovigilance from the very start, when we had our first report in the 1996, and we started having a chapter focusing on the donor Haemovigilance from the 2016 annual SHOT report. And how we do that is slightly different to what we have in the recipient Haemovigilance. Now, we have a working group with members of the UK blood services, the 4 UK blood services, and we then actually discuss the collated cases from the 4 blood services and focus primarily on the most severe donor adverse events. The important thing that I would like to stress is Haemovigilance is not just collection of the report for collection's sake. it must be resulting in improvements. It must be actually then enhancing transfusion safety. So everything is about the impact. It is about what is the effect that it has on the safety. So how do we actually then learn, use the insights that we get from the Haemovigilance to actually then make a difference? And that is where we are actually here today as well. So from our work on the donor Haemovigilance, working together with the JPAC SAC CSD, based on the themes that we have actually found, what are the things that we are doing to improve the donor safety as well? Okay, we come on to the next one as well. Now, every year we bring out an annual report which covers the preceding year's events that have been actually then reported. So as I said, for the donor Haemovigilance, it is actually the all the incidents that have been reported to the respective blood services in the previous year. So right now we are working on the 2025 annual short report, which would be released in July. So this is usually at our symposium. So here is the QR code to actually take you to the annual short report, and there you will also be able to have the link for the donor Haemovigilance resource. We also produce a summary infographic as well, and we have colleagues from the CST as well as the donor medical team who work with us from NHSBT as well. If you go on to the next one. Now, some of the key highlights, I mean, this is not primarily covering what we have learned from the donor Haemovigilance chapter, but I just want to actually then enhance this. Now, roughly around the UK, we have 2.2 million blood components that are issued to the patients in the hospitals, and all of them come from voluntary non-remunerated donation. And we do actually look at what are the common themes. And when we look at the severe donor adverse events, it is primarily the arm pain relating to the needle insertion and vasovagal events recurringly, in every year on year, they seem to be the most commonly reported serious donor complications. What we've also been doing is taking on from what has been happening internationally. We have implemented the severity grading criteria for the donor complications. Now, a few of the blood services have already implemented this, and some are still in the planning and implementation stage. So it is in progress, but we are hoping in the next year or so, we will have all the 4 blood services. What that means is, irrespective of the complication that has been reported by the donor, we are then able to categorize whether it is in the milder end of the spectrum or the more severe end. And these are grades 1 to 5 that we have reported. And this can allow us to benchmark with what is happening internationally. But we also know that there are problems with the delayed donor adverse events report. So we need to really look at measures how we can improve the reporting of all the adverse events. And that relies on the donors to actually then report to us. They may sometimes self-withdraw. So we are really looking at how we can actually then improve awareness as well as reporting of the donor adverse events, especially the delayed ones. So please do have a look at the donor Haemovigilance chapter as well. There we give a rate. SAD is the older definition where we had 10 different criteria, 10 different events which could be classified as serious adverse events of donation. And now the SDC stands for the serious donor complications, which are grade 3 and higher as per the newer definitions. So largely donations are safe, but we always look at when things have gone wrong, are there any preventable factors? What can we learn from it? And how can we actually then address those factors and improve the safety? So thank you. And I'll hand you on to Jayne to cover the next section.
Thank you, Shruthi. And so I'm going to follow from Shruthi by talking a little bit about JPAC, which is the other side of this donor Haemovigilance hub. JPAC is the organisation that's hosting the hub on their website. I thought it'd be good to give you a bit of background to that before we get into the hub itself. So JPAC, if you work in the UK, you'll be familiar with the term. What it stands for is the Joint United Kingdom Blood Transfusion and Tissue Transplantation Services Professional Advisory Committee. Quite hard to say that with one breath. And as you can see, the J does a lot of work in that acronym, so you can see why we call it JPAC. JPAC itself has 2 kind of main purposes, 2 aims. One is to be an advisory committee to the 4 UK blood transfusion and tissue transplantation services, and the other is to prepare the detailed guidelines for those services to use on a day-to-day basis. JPAC itself is made up of a small core team, which are headed by the professional director, who's Dr. Stephen Thomas, and they report into the UK Forum, which is the 4 UK medical directors and the 4 directors of the UK services. But that JPAC office and the JPAC board are supported by a number of standing advisory committees, which are drawn from expertise within the services to give a broad kind of overview of all the various activities that transfusion and tissue transplant services will be doing. So if we could move on to the next slide, please, Liezl. Oh, it seems to be a wee bit, yep, brilliant, good. So I'm chair of the Standing Advisory Committee for the Care and Selection of Donors. And our remit is really to provide guidance on staffing, environment, equipment and procedures for blood donation sessions. So that is really chapters 3, 4 and 5 of the Red Book, which you'll be familiar, that's the kind of UK guidelines which are produced by JPAC. And that covers everything that's happening in terms of the blood donor coming to session and giving blood. We also have a responsibility to review and update the donor selection guidelines for blood donors, and that's particularly the whole blood and components guidelines, WBDSG, and also the Geographical Disease Risk Index, or the GDRI. And as part of that work of both those activities, we need to coordinate with our colleagues in the other standing advisory committees. So there's committees for cellular therapies and tissues, where we try and coordinate our donor selection activity as much as we can. And also the Committee for Transfusion Transmitted Infections. It's very important that we keep up to date with the output from SACT and update our guidelines on the basis of what they're telling us about what risks there are for blood donations out there. Next slide, please, Liezl. So that donor selection work was very much a focus of what we were doing when I started on the SAC quite a few years ago now. But we realised that there was a bit of a gap because the name was Care and Selection of Donors, and we weren't doing a lot of the care side of things at that point with the output that we were producing from the committee. So under the leadership of the previous chair, Dr. Angus Wells, we really started to shift to have a focus on donor care and seeing donor care as a priority in the output from SAC-CSD. And that sort of coordinated quite well with the work that Shruthi was doing with SHOT. So we started a degree of collaborative work with SHOT to try and really promote donor haemovigilance. And some of the things that we've done are looking at how we can standardise donor adverse event recording, and you've already heard a little bit about that. We had the SHOT donor haemovigilance chapter, which Shruthi mentioned earlier. And we've also started the development of shared good practice documents. And these are documents that will have a UK-wide focus. So we're working kind of out with the individual service structure, but working on a UK level to try and get things that will work across the board so that we can have a fairly standard approach across all of the UK. And we've now got enough in terms of documentation that we've produced to be in a place where we can launch the Donor Haemovigilance Hub, which is why you're here today. So I'm going to pass on now to Liezl Gaum to speak about the Donor Haemovigilance Hub in a bit more detail. Thank you, Liezl.
Thanks, Jayne. So as Jayne led us into this, I'm just introducing you to the Donor Haemovigilance Hub. And as Shruthi's already covered haemovigilance, I've just quoted here the definition of donor haemovigilance as it's captured in the annual SHOT report in the donor haemovigilance chapter every year. So it's the systematic monitoring of adverse reactions and incidents in the whole chain of blood donor care with a view to improve quality and safety for blood donors. So what is the hub? It's a new page on the JPAC website. It can be found in the document library and it's dedicated to donor haemovigilance. And I'll show you in a couple of slides exactly where you can find it at present on the website as it is at the moment. The hub is there to provide practical and evidence-based resources to help enhance donor care and safety. And it's also there to share the learning and the real-world insights that the various working groups who worked on the resources that is there, what they've learned and what they've gathered to put into those resources for colleagues to read through and learn from as well. And all of that is to support the continuous improvement in donor care, as Jayne's just mentioned as well. The care of the donor is vital. So why was the hub created? The protection of blood donors, as you've heard, is vital. So that forms the foundation of us having a safe, sustainable and reliable blood supply. But unfortunately, as we know, donor adverse events, for example, arm complications and vasovagal reactions that Shruthi's mentioned, are known and recognized complications of donation. So we know what happens even despite our best efforts to try and improve the donor journey and avoid these. we can't get away from it, and they do occur. And that can impact the donor's donation journey, their experience, and also potentially their eligibility to carry on to donate. And that then feeds back to the donor base and our aim to try and maintain the sustainable and reliable blood supply. And if we lose donors along the way, that is obviously affected. So the hub, the resources that's on there were created to capture every information and details related to the different donor adverse events that can occur. And the aim of these is to benefit staff who manage donors, who face these donors on session or when it's a delayed reaction afterwards, when they've experienced an adverse reaction, and the resources are there to be a helping hand, so to speak. So the aim of it, why did we create it? The intention of Hughes is to, as I've just said, to bring value to staff in their day-to-day practice and to act as sort of a aid memoir, if you want. For example, when where a staff member have to discuss an event with a donor, to remember what questions to ask, because when you're in the heat of the moment with a donor, you might forget something. So the resources are there that colleagues will show you shortly and go through them as well. They're there to help ensure that all the relevant questions are captured and asked, and the information is captured about the event, which then leads us into the second point there, to aid documentation, to make sure that we capture the whole event, all the relevant information is there on the donor's record for if they come back to us in future or for future use when we review at this event, and where can we improve things if we look back at this. So it's vital to make sure that we capture everything about the event that's happened with the donor. But it's also the resources are there to assist training of staff, to help them with the management of the donor and the event they've experienced. And this is especially helpful, we think, to staff who's new to a blood service. If you're not aware of the events that can happen with a donor, and you don't quite know what to ask and what you need to gather from them, these resources is a very helpful resource to help them go through the questions, and is there to develop their confidence when managing a donor who's experienced the event as well. And this is a screenshot of the Donor Haemovigilance Hub, and you can see at the top right corner, it says about JPAC, latest updates, and then document library. And if you click on document library on the main screen, it takes you to this site, and you can click the bottom there. It will take you to Donor Haemovigilance, and that's where you can find the hub. And then the QR code is there for you to access as well. And next is my colleague Hasarika from the Welsh Blood Service, and she'll go through some of the resources that we've collated for you. Thanks.
Thank you, Liezl. So I will talk through the toolkits for assessment of donor adverse events. Next slide, please, Liezl. Most of the time, the blood donation is very safe and straightforward process, but occasionally donors do experience complications. When that happens, how we assess and manage these situations really matters. So these documents are there to support us when we are assessing donors who have experienced complications after giving blood, especially when during the follow-up assessment. These documents focus on three main areas. The first is vasovagal reactions. That includes both immediate and delayed events. So whether donor faints or just feel faint without losing consciousness, there are structured guidance to support that assessment. The second area is suspected allergic reactions. That guidance help us to assess the full range from mild localized skin reactions right through to more severe generalized reactions, including anaphylaxis. Next slide, please, Liezl. The third area is arm complication, which includes potential injuries to blood vessels, nerves, or tendons. And also it supports assessing symptoms ranging from common issues like bruising to rare but more serious complications such as compartment syndrome. One of the really helpful part of the arm complication toolkit is the symptom-based summary table. As you can see here, this link specific symptoms and signs to possible underlying causes. It acts as a decision support tool but it also can be used as a training tool, especially when guiding staff through more complex or uncertain presentations. Overall, these previous slide, please, Liezl. Overall, these documents provide a systematic way to approach assessment and help us recognize red flag symptoms early, guide appropriate follow-up, and also support decisions about future donation eligibility. And I think it is really important to emphasize these toolkits support clinical judgment. They do not replace it. Okay, next slide, please, Liezl. They are designed for healthcare professionals who are responsible for assessing donors who may have experienced an adverse event after donation. The reporting of donor complications hasn't always been consistent across blood services, and definitions have sometimes differed, and assessment haven't always been approached in the same way. So these guidance were developed to bring more structure and consistency, both in how we assess donors and how we report adverse events. Next slide, please. They are created by a working group of experienced donor care doctors and nurses from all UK blood services, and then they were then reviewed and strengthened with feedback from nurses across each service. So that we have is guidance that combines evidence-based practice with extensive clinical experience. The overall aim of these documents is to strengthen the assessment process, support consistent reporting, and help us make accurate diagnosis and appropriate management decisions for donors and their donations. So ultimately, these toolkits are not just documents. They are practical tools that help us protect donor safety, strengthen our assessment, and ensure higher standards of care. Thank you. Now I will hand over to Rebecca. She will take you through good venipuncture practice.
Hello. Hello, everybody. Can I have the slide, please?
Apologies, Rebecca.
It's
I
okay.
have a gremlin in the system now.
That's okay.
It does not want to move.
Thank you for joining us today, everybody.
I'll share the screen, Liezl, don't worry.
Thank you.
I think IT issues are part and parcel of our day-to-day life now. I'll just put that on presentation view.
That's great. Thank you, Shruthi.
Yeah.
Hello, everybody. My name's Becky Hutchinson. I'm one of the regional lead nurses for the Nursing and Care Quality Team for NHS Blood and Transplant. Thank you very much for joining us today. Myself and Dr. Jayne Hughes put together this presentation for good venipuncture practice within blood donation. Our aim is to undertake this work was to produce a clear, comprehensive document outlining the full practice of venipuncture, beginning from the moment that the donor agrees to donate and is guided to the donation chair or bed, through to the point at which the donor leaves the donation area. The document was developed to support safe, consistent and high quality practice by providing detailed guidance along with training and monitoring recommendations for all venipuncturists. And the document was developed through Accidental Arterial Puncture Working Group, which was a short life subgroup of SACHI's SD and SHOT. May I have the next slide, please? Thank you. So we came up with two aims, as you can see on the slide here. So the first aim was to provide good practice for blood donation venipuncture, promoting donor and recipient safety, and also to provide standards for the training and monitoring of blood donation venipuncture. Now, venipuncture practice and training across the 4 UK blood transfusion services were reviewed to develop an overarching set of good practice principles that can be applied within each individual service. And these principles align with the relevant sections of the Guidance for Blood Transfusion Services in the UK. You might know that as the Red Book Guidelines, and the European Directorate for the Quality of Medicines and Healthcare. And that's Guide to the Preparation, Use and Quality Assurance of Blood Components. That was the 22nd edition, which was last year, 2025. So reviewed practice across all 4 services, focus specifically on identifying any safety related gaps. So our aim was to ensure consistency, reduce risk and strengthen shared standards. So let's look at the aims in a bit closer detail. If I could have the next slide, please. Thank you. So a good venipuncture practice, as you can see, there's quite a few things within this that myself and Jayne took a look at. First one was approaching the donor. So VP is carried out once the donor has completed health screening and the consent process. And donation staff must adopt a professional but a friendly tone and using neutral language. And this should place the donor at ease for the procedure. And the donor must confirm their identity prior to venipuncture, and this includes full name, date of birth and full address. The anatomy of the antecubital fossa area, obviously, as you can appreciate, extremely important. As you know, this is a triangular depression lying in front of the elbow when the arm is outstretched, and it's used for blood donation venipuncture as it contains the most accessible veins of sufficient calibre to support the collection of a large volume of blood. Within this area, we'll also find structures such as the median basilic and cephalic vein, the brachial artery, and the biceps tendon and various nerves. And vein assessment should only be carried out once the donor is comfortably positioned on the donation chair or bed, ensuring that their arm is well supported. Vein selection, extremely important. Care must be taken when assessing a donor's arm for a suitable vein selection. They should be assessed in a reclined position and their arm in a comfortable position. And the donation staff need to identify the position of the brachial artery first to develop a mind map so they know exactly where they're going. This should be undertaken when the pressure or the tourniquet is down. It's down to 0 so that we're feeling for that artery. That's really important before we even look for and assess for any veins. Once the pressure has been applied, generally between 40 to 60 mmHgs, then staff can have a look and a feel. And we're looking for really good bouncy veins, and we're looking at the location. So is the vein straight? Is it well anchored? Easy to secure the needle? Skin condition is the area free from inflammation and any open wounds. We're trying to avoid scarring, blemishes, and any previous bruising that may have occurred from, previous blood tests. And also the size of the veins is really important as well. It's to accommodate that donation needle. It's 16 gauge, and obviously again to run in a straight line. So we tend to go for the median cubital vein. Tend to be the really good vein of choice for all the above reasons. They tend to found furthest away from the brachial artery and the biceps tendon and the bundle of nerves as well. So really good one to go for. And then obviously we'd then go for the cephalic and the basilic. Now both arms, should be assessed if the venipuncturist isn't sure, and they should always ask for a second opinion from another experienced venipuncturist. If nothing can be found on that day, then the venipuncture should not take place. We should keep the donor at the forefront of our care, okay? And obviously this should be explained to the donor, the reasons why we can't go forward that day. Infection prevention control, again, extremely important. We must maintain strict hand hygiene. We tend to look at the 7-stage hand washing technique, which is used in the General National Health Service. And this must take place prior to venipuncture and prior to the removal of a needle as well. Staff must use validated cleaning solutions to make their hands hygienically clean, and obviously follow the skin cleaning procedures required by their service, using all the techniques mandated by their SOPs. It's important that the cleaning solution is given time to dry as well prior to needle insertion. That'll make it a lot more comfortable for the donor. Sterile, single-use only equipment is to be used, and the area must not be touched once cleaned. The actual technique, well, we're looking for the donor's arm in a comfortable position to start with. We're using a no-touch technique, and we're inserting the needle in a single smooth motion at roughly a 45-degree angle. We're going to advance steadily into the vein until blood flow is seen. Now, sometimes a slow flow or no blood flow seen. So yes, we can adjust the needle, but we're only looking at the once for whole blood donation. That's either a rotation of 180 degrees or a withdrawal of the needle. There shouldn't be any advancement of the needle at all. That could only cause a lot of problems such as pain and damage to the internal structures in the antecubital fossa area. Adjustment must be documented on the donor's paperwork, and don't pass the needle over to another member of staff to adjust, as they haven't made that initial assessment, so they won't have that mind map of the area. Don't move the armrest while the needle is in the donor's arm neither. Once the needle's inserted, again, that can cause a lot of damage to the area. And if you do remove the tape and the needle moves itself, that is classed as a needle adjustment as well. We'd secure the needle to donor's skin with the tape, or a bandage, of course, if the donor is allergic to the tape being used. Monitoring of the donor during donation is, again, extremely important. We're looking for any adverse events that occur. It can occur at any point in that donation. We're looking at the donor's pallor. Do they look nervous? Are they yawning? Are they fidgeting? Or are they actually telling you that they feel unwell? It's important that staff talk with the donors on a regular basis during donation, especially with donors that may be vulnerable. For example, first-time donors or donors that have had adverse events in the past. So staff are looking for vasovagal symptoms. If so, they'd lie the donor down, elevate the leg, remove the needle. Pain, that can be expressed verbally or non-verbally. Again, we'd be removing the needle straight away for any sustained severe pain. Hematoma formation, again, needle straight out, plenty of pressure on that arm. And obviously suspected arterial puncture, again, remove the needle straight away, and we would apply firm pressure to that arm. You may sometimes get suspected nerve or tendon injuries, so you're looking for that electric shock kind of pain, any tingling or numbness. Other tingling you may get as well with our component donors is a tingling in the lips, and obviously that might suggest a citrate reaction. Again, you would follow your standard operating procedures regarding that, with pausing or even stopping that donation. If you have any adverse events, donor carers and healthcare assistants must inform the clinical lead, the nurse on session, so that he or she can assess that donor to see if anything needs escalating to the medics at all. Ending the venipuncture. So once a full donation has been achieved, it's usually either the maximum time has been reached, we've got a full donation, or there's been an adverse event. We're going to deflate the cuff to 0 and apply a clamp to the bleed line. We're going to place sterile gauze over the VP site, and in a single smooth movement, we're going to remove the needle into the needle guard, maintaining the same angle as it was put in if possible. Apply firm pressure to the VP site. Follow your local procedures, but 2 minutes does appear to be the minimum time to achieve great hemostasis. We're going to ask the donor to take over this procedure if they can. That's absolutely fine. And obviously not to dab the VP site. We don't want to stop that clotting cascade from happening. We're going to apply a dressing. Follow your local procedures. We all use different dressings out there. There are hemostatic plasters that can be used. They do reduce the risk of delayed bleeding after venipuncture, and these are applied at the same time as the removal of the needle. But services must ensure instructions for their application are incorporated into the standard operating procedures, and staff, of course, are fully trained to use them. And once the above has been achieved, the donor's arm should be checked prior to them leaving the donation area, making sure all bleeding has stopped and the donor's feeling well. Managing unsuccessful venipuncture is also important. Not everything runs smoothly, as you know, and services must have SOPs and training in place to manage unsuccessful venipunctures and donor adverse events, including when post-donation follow-up is also required. Services must also have a mechanism in place to ensure recording and reporting of donors' adverse events, as described in the Red Book guidelines, which is on Chapter 5.10. Donors must be carefully observed during and after the donation, and staff need to observe both verbal and non-verbal cues from the donors. And action should be taken as soon as an issue with the donation or the donor is identified. And a second donation on the same arm must not be attempted if the donor is still experiencing pain, numbness, or severe bruising. The main thing to get from this is that donation should never be prioritised over donor well-being. May I have the next slide, please? Thank you. So our second aim was training and monitoring of blood donation venipuncture. So the training approach, so good VP practice starts with a robust training programme, and that will give the trainee the knowledge and the confidence to undertake the clinical skill. And if the trainee has been trained to a high standard, then the outcome for the donor and the recipient will be a safe and positive one. So we're looking at a blended approach, both theory and practical, occupational experience, knowledge of the theoretical aspects of the clinical skills, knowledge of the standard operating procedures relating to venipuncture, and also knowledge of training methods, how to support staff with neurodivergence issues. And services are to provide access to appropriate training for the trainers. This could be professional qualifications or in-house training. The content of the training programme should include anatomy and physiology of the antecubital fossa, structures found in that area, vein selection, infection and prevention control, venipuncture technique, observation during donation, and management and documenting adverse events from vasovagal bruising, rebleeds up to allergy reactions and suspected arterial punctures. Completion of the donation should also be touched on, and assessment of the clinical skill as well. Also, another major thing is good customer practice and good customer care, donor-focused approach, communication skills, using neutral language regarding venipuncture. For example, what we don't want to hear is, oh, sharp scratch, or this may hurt a bit. What we're looking for is, I'm just going to start your donation. This will put the donor more at ease and make the donation experience a lot nicer for them. They need to also explain that they're in training. That actually gives the donor the opportunity to ask for somebody more experienced. That gives them a bigger part of informed consent as well. Assessment of VP competency is another major factor of training and monitoring. Services must have a process in place to ensure that individuals undergoing VP training are safe to practice before being signed off as trained, and individuals will require a period of consolidation to develop their VP skills and confidence and become fully competent in the skill. Assessment should be both theoretical and practical, and formative and summative assessments have been found a robust process to follow. Observation of clinical skills and written tests and multiple choice questions can be used. Demonstration of a skill, verbal instead of written. And reading of underpinning knowledge and signing, obviously, the standard operating procedures. Assessment methods need to support equality, diversity and inclusion. And constructive feedback is also extremely important, and it needs to be given to the trainee working under direct supervision of the trainer. Monitoring of VP performance, this ongoing monitoring, again, extremely important in what we do. All services should monitor VP performance, both for individual staff and for the service or teams within it. Observation by the clinical lead on session would be a big part of this, and review of VP statistics, key performance indicators of individuals and of the teams as well. Formal audit of individuals and teams. Investigation of quality incidents relating to venipuncture, and investigation following donor complaints and feedback. And as part of the monitoring process, services should have in place targets associated with key performance indicators. And suggested KPIs could be looking at failed venipunctures, underweight donations, contaminated donations, and donation adverse events. Here we've got a lovely diagram by kind permission of Ewan Burton, who is a medical student. He drew this of the antecubital fossa area and the structures that can be found in it. Obviously, this is something that the trainee will be trained on to look exactly to see where they're going. Main one being looking for that artery first before looking for those veins. May I have the next slide, please? Thank you. Just some references and acknowledgements there. We've got the guidelines for the UK Blood Transfusion Services, or the Red Book. You can find it on the website, and the DQM Guide to the Preparation, Uses and Quality Insurance of Blood. I'd like to show acknowledgement to members of SACSD AAP Working Group, chaired by Dr. J.B. Mueller, and I'd also like to thank the Education and Training Department, the NHS Blood and Transplant, for the training content regarding the venipuncture that I've shared with you today. Thank you. I'd like to hand you over to my colleague now, Dr. J.B. Mueller, who's going to talk to you about accidental arterial puncture. Thank you.
Thank you very much, Rebecca, and good afternoon. The Accidental Arterial Puncture group was a collaborative project between SACSD and SHOT. It was a task and finish group and nursing from all 4 United Kingdom blood transfusion services and Irish blood transfusion service, with a special acknowledgement to the Royal College of Surgeons of England for the Vascular Society of Great Britain and Ireland for their contributions to the final draft and comments and suggestions. Arm complications makes up 30% of all whole blood donations adverse events. Of these, accidental arterial punctures are very rare adverse events, which tends to do very well if recognized and managed appropriately. The following steps are very important in the management of arterial punctures. Early recognition at session is very important, timely treatment, and appropriate advice. And the above mentioned steps are paramount to help avert very rare serious complications such as pseudoaneurysm formation, arteriovenous fistula formation, and compartment syndrome. The group focused guidance to provide an overview of best practice in the management of an accidental arterial puncture during blood donation, and to support healthcare professionals in assessment and management of donors experiencing signs and symptoms suggestive of accidental arterial punctures, and also to ensure a consistent approach across the UK and Irish blood transfusion services. 2 distinct areas were covered, regarding identification and management of arterial punctures, accidental arterial punctures, at session, and then also once the donor has left the session. Other aspects we covered: risk factors, understanding these can help to minimize AAPs, advice to GP and healthcare professionals for care and management, and follow-up of the donor. And this project also led to the development of the good venipuncture practice, which Rebecca has kindly shared with us before in a very thorough detail. The key recommendations in 3 categories: on session, off session, and future donations. On session, very importantly, if in doubt, treat as an arterial puncture. Accurate, comprehensive documentation is essential. Digital pressure with 3 fingers over the affected area for 10 minutes with effective pressure bandage afterwards is paramount. Review the donor prior to the donor leaving the session. Off session, donor to avoid any strenuous activity with that arm. When assessing the arm complications, symptoms, one needs to consider whether accidental arterial puncture was missed at the session and discovered by the donor or reported by the donor following a donation once they left the session. There's also the case where processing and manufacturing may inform medical staff of suspicious donations, bright red frothy units in the manufacturing side. And in future donations, avoid that affected arm not to be used for donations. I think that is it. There's some references, but thank you very much.
Thank you, JB. And it's come back to me now to talk a little bit more about the practical application of all of this. So if you can move to the next slide, please, Shruthi. So we've already touched quite a bit on why we should be using the Donor Haemovigilance Hub, but what I really wanted to say to attendees today and to people who are listening to this webinar afterwards is have a think about how you can actually maximise some of the benefits of the documents that we've prepared for you. We've put a lot of work into it and we would like them to be used. I think there's 3 things that we've covered a little bit already. I think there's a lot of information there which is good for the guidance that we use in our transfusion services around how we run our sessions, how we perform venipuncture, how we manage some of the complications of venipuncture, how we assess when things go wrong. So have a look at that, and if you're involved in writing SOPs or anything like that, then please do have a look and see if there's any nuggets of information that you could put into your procedures. There's nothing strange or startling on the Haemovigilance Hub, but there may be bits and pieces that could just improve what you've got already a little bit. So have a look and see. We're keen on benchmarking. We want to try and standardise things as much as possible across the 4 UK services so that we've got more comparable data, and that also will put us in a better position for looking at our information globally about how well our donors do with blood donation. So that benchmarking piece is important, and using those, for example, the questionnaires, the suggested kind of assessment of donors with adverse events will be particularly helpful in that, not only in categorizing those events, but also in providing more detail, more information, more consistent information about why things occur, and that might help us to develop better approaches to avoiding those in the future. And for training and education purposes, there's a lot of information there, really, really useful. We've emphasised that through the session today. But I would say this information is free to use for whoever wants to use it, but please do acknowledge the source if you're using any of the resources that we've produced. It should be acknowledged in whatever you do. Next slide, please, Liezl. Very quickly, I just want to give an example of how you can use this in the service. And this is from something that we've done up in Scotland with our very first document, which was the post-donation management of nerve injury way back in 2020. This one was produced and it was reviewed in 2025. So we're on the 2nd edition now. This was from a short life working group with donor clinicians from across the 4 UK services and our colleagues in the Irish blood transfusion service as well. So really getting that collaborative approach. And we came up with a set of guidelines for management of a particularly difficult donor adverse event in donors. We also got expert opinion, as JB's already spoken about with the AAP group. We got some neurologists and neurophysiologists to look at this to make sure we got it right. So we've produced a document. It's full of excellent advice and information, but it's 19 pages long. You can't roll it out in the middle of a phone call to the donor. You've got to do something. How are we going to put this into practice for our staff? I'm not very good at retaining stuff, so I'm not going to remember all of this if you try and teach me it. So next slide, please, Liezl. What we did in Scotland was we made it into a tool for our staff to use. We have a thing called the DS Toolkit, which is an online platform that we use to present our donor selection guidelines to staff, but we can put operational stuff in there as well. So we created a page on that for adverse events, arm symptoms, and it gave a list of instructions to our clinical support team, nursing staff, and our donor medical team, who are the people who'll be dealing with these donors, on the type of questions that you should be asking donors. What should you ask them? It told us not only what to ask the donors, but what do you do with that information and what do you tell the donor. So we were able to distill the essence of that nerve injury document into a much shorter thing that staff can access quite easily at session. So, be creative, go away, have a look at what we've got and see what you can do for your staff to try and use some of the other resources and things that we've got on there. Next slide, please. Just finally, these documents are subject to a review and governance procedure. They're owned by SACS-CSD. They'll be managed through our work plan. And for most of these haemovigilance documents, we'll be looking at a 3-yearly review for them. So if you've been involved with writing one of them, I've got bad news for you. I might be coming back to you in a year or two to try and get some review of that document. But those reviews will go through the standard approval processes with JPAC. I'm not anticipating major changes, but there may be little snippets and things to improve. So we'll keep you up to date if there's any new issues of these coming out. And that's all I wanted to say about that just now. I think I'll hand back to Shruthi.
Yeah, thanks very much, Jayne, and thanks to all my colleagues as well. So I think the important thing to actually mention is this is a dynamic compendium of resources. So we will keep adding to this as we actually then go through the process. As Jayne has mentioned, it is actually the regular review and update. So please, when you start using these and you have anything that you want to actually feedback, either contact us at SHOT or at JPAC as well. The contact details are there on the Donor Haemovigilance Hub. That would actually allow us to actually incorporate. And remember, these are going back to the principles, although there may be slight variations to the practices based on your SOPs in your blood service as well. We are planning to add new documents in the future, so it actually comes to capacity and prioritization. So if you feel that there are any particular areas that would actually be, underrepresented and we would like to actually then add on, please do again reach out to us. And also, as Jayne has actually then said, we may have spent a lot of time producing these documents, but it is ultimately the value is in using them in day-to-day practices. So please do help promote them, share them widely, think about what are the ways that you can actually incorporate, whether it is actually in induction training for new staff or refresher training of the staff, incorporating it, because I think the main thing is how do we ensure standardization of the practices across, ensure that whatever history taking and that we actually have, from the clinical features is actually then allowing us to gather adequate insights about the donor adverse events as well. And also we do want it to be actually having these feedback loops. Now, although we have had iterative, feedback throughout this process, I think ultimately, we want, much wider. So when you start using it, are there any things that are good about it that you like, or are there any issues that you would like to actually then share with us as well? I would also like to take this opportunity to share a couple of things. Now, this is primarily recipient focused, but you're quite welcome to actually then join us because it is about improving the transfusion safety. So along with the MHRA, we are running haemovigilance workshops. We have done to date in Scotland, Wales, as well as the Northern Ireland, and there are 2 workshops in England. So these are free for staff to actually then attend, but we won't be covering the travel and accommodation, but there are details on the SHOT website. So please do have a look and then join us if possible. There are 2 identical workshops. You only need to actually then attend one. So one is in the north and one is in the south. And also, as I mentioned, we are celebrating 30 years of haemovigilance, and we release the annual SHOT report, which also has the donor chapter as well every year at our symposium. And the symposium this year is on 10th of July, Friday, and is at Birmingham. So please do, again, registrations are open. So are abstract submissions. So any quality improvement project audit, any work that you have actually then done as well, please do actually then share it with us. And I think, we have demonstrated through the, last 50 minutes or so, how this has been very much a collaborative effort. So although a few of us have actually then come here and joined, it is actually the collective input from a lot of staff supporting us from the 4 UK blood services. So I would like to really take this moment to, first and foremost, thank all our blood donors, because without their altruistic donations, no transfusions can actually take place. But to all of you, who are part of the donor journey, who are supporting and looking after the donors and the donor safety, and everybody who have directly contributed to this document as well. So really a big thank you from everybody, both at JPAC as well as SHOT as well. So I think we have time for a couple of questions. So I'll stop sharing now. Over to Karen. I think we have just 1 or 2 questions that have come in. So please do share if you have any questions as well. I know time is limited, but if there are things that we can cover and clarify, we can do that.
Thank you, Shruthi. And we have a question from Sasha. Thank you to Sasha, who's put this question in. And her feedback is, the hub looks brilliant. Some resources on there I wish I had access to when working in blood collection. But her questions are 2 questions. What is your cascade plan to make donor carers, donor care supervisors and session nurses aware of the resources? And the second part of the question is, how have the resources been received during donor care training?
Yeah, thank you, Sasha. A great question, and thanks for the lovely feedback as well. And as I said, I think this has taken most part of two years or so to get all the documents together. Although the nerve injury one was actually released 5 years ago. I think it was recognized internationally as well, where people were actually then asking, and I think Jayne did go to ABB and then did a short presentation there as well. I think the challenge is actually in that implementation, and while we can't force or mandate, it is actually ultimately to those who are involved in the training in the 4 blood services as well to think about where best it would actually then fit in. And as I think Jayne has identified, practically incorporating it. So, that is there as a guidance. What part of it can you actually then incorporate to the training of the staff as well? So I think it would be useful to hear from even Rebecca. I think you with your hat on as part of the NCQT within NHSBT, what are your thoughts? And equally, my colleagues from the other blood services as well to come in. I mean, largely people who have actually been involved in the feedback, they have been very positive. Because I think it actually provides those forms, because I think, as people may be aware, donor management with the blood services, other than when they come on sessions, is largely through phone, which produces its own challenges. So I think ensuring that you're able to actually then have this kind of a ready reckoner or an aid member to actually then ask those questions will always be actually then very useful. Rebecca, over to you.
JPAC guidelines. Can you hear me? Sorry.
Yeah.
Yes.
Thank you. Just having problems with this. JPAC guidelines are embedded in NHS blood and transplant training anyway. I can obviously just talk about the England side. I think we do need to get it out more often, especially on team training days and other webinars as well, to get it out, you know, to all the blood donation teams. The problems that we have obviously is getting people to attend webinars and to learn more about this, but when they're out working on the teams, it can be very tough. So team training days would be fantastic to you know, get this information and escalate this information out there.
I don't know, Hasarika, do you want to come in as well from Wales? How do you think they're using it?
Yes, especially our training colleagues, so they use these resources for their training purposes. Yeah, I'm not very much involved in training in Wales, so yeah, that's.
I think we have colleagues raising their hands. I'm not sure whether we can actually then unmute with the settings that have been put in, but I would be really grateful, Jill and Liezl, Jayne, if you can put in the chat as well. Not chat, I mean, the Q&A function, if you put in your comments, and we will take notice of that. But I think, yeah, really this is just the initial part of our, you know, this is one way that we are actually then using the webinar to actually then share this widely with you all. And I think it is, you know, it's an ongoing process. We will keep track of the analytics on the page as well. So regularly at the SAC CST meetings to actually then see how many people have accessed and how many have downloaded this. But it would be actually useful to get that feedback from all the 4 UK blood services as well.
Thank you, everybody. I'm afraid we're out of time, so apologies if we haven't been able to get to your question. As Shruthi said, Jill and Liezl, Jayne, if you can either pop your thing in the Q&A or comments, or email us at SHOT or JPAC, we'll be very grateful for any of your feedback. In the last few minutes of this webinar, we're going to do a poll, which should be appearing on your screen shortly, for you to submit your questions. We really do appreciate you taking a few minutes to complete this, as it helps guide our future resources and webinars. Just a reminder, this session has been recorded and will be uploaded onto the SHOT website over the next couple of weeks, so please keep an eye out for that. And as I've already said, we really do appreciate all your feedback and comments about haemovigilance in general, so please do get in touch with us and JPAC via email. As already mentioned, please visit the JPAC and SHOT websites for additional reports and resources. They're freely available for you to use for your educational activities. And finally, a huge thank you to all the speakers and panelists today. I think all the presentations have given us a lot of food for thought, especially those working in the donor sessions, and also to our admin team who have been working in the background to help us running things smoothly. We thank you also to all of you who have joined us today, and we hope to see you again soon. Thank you.